I started yet.
He continued to contribute as a professor until his retirement in 1999. Crutchfield was recognized for his achievement and received several prestigious awards, including the Virginia Press Association Lifetime's Achievement Award in 2009. George unfortunately passed away in March 2011 at the age of 77. George had a strong interest in cardiovascular disease and the work of Dr. George Vetrobeck and Dr. Hess. His desire to further education in heart disease continues through this fund. We thank Francis and George's family for providing this opportunity to welcome our 2023 Broaddus Crutchfield lecture speaker. Our speaker today is Dr. Lewis. He is a cardiologist who currently serves as section head of heart failure, medical director of heart transplantation, and director of cardiopulmonary exercise testing at Massachusetts General Hospital. He's a professor of medicine at Harvard. Dr. Lewis cares for patients with a wide range of cardiovascular disease while also leading patient-oriented research initiatives aimed at improving functional capacity and prognosis in patients with heart failure. As an investigator, he has continuously been funded by the NIH since 2006 and has published over 200 manuscripts in the field, ranging from evolution of new therapies for heart failure to further understand hemodynamic profiles and physiologic subtypes of cardiovascular diseases. His human physiology laboratory couples perturbational phenotyping with metabolic profiling of human plasma at rest and during exercise in collaboration with the Broad Institute. The Massachusetts General Hospital Cardiopulmonary Exercise Testing Laboratory also served as the core lab for several National Institute of Health networks, as well as the national and international clinical trials. We are grateful for Dr. Lewis' expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. If you have any question and you're on Zoom, please submit the question through the chat function as they arise during the talk. We are also pleased to offer both CME and MOC credit for Grand Rounds conference series. To claim the credit for today's session, you will see a code. You will text the code to the number that will be provided at the beginning at the end of this lecture. I will now turn it over to Dr. Lewis to go ahead and give the lecture. Thank you, Dr. Lewis.
Thank you.
Thank you for that kind introduction. Hopefully those online will be able to hear me okay. This is some information, it looks like, for CME. So it is a real honor to be here. I appreciate the kind introduction. Appreciate the invitation to join all of you today. We just heard about Professor Crutchfield and his distinguished career. I also was pleased with the legacy of Dr. Hess, who I know cared for Mr. Crutchfield as a professor of medicine and physiology, as well as Kair Shah, who I know was a mentee of Dr. Hess. And I certainly serve as a member of the International Society of Heart and Lung Transplant that he founded, and I'm familiar with the rich history here. So it's a real honor to be here today with all of you. And in light of Dr. Hess's many contributions to medicine and to physiology, I elected to focus on exercise as a physiologic probe in heart failure for my comments this morning. Here are my disclosures. These companies predominantly fund research through institutional agreements with Mass General, not through me personally. So we're going to talk about heart failure this morning. We know that there's an overwhelming burden at the societal level. About 2% of the population suffers from heart failure, over 1 million hospitalizations annually, including the #1 cause of hospitalization for those over the age of 65, with staggering societal costs. And I'm going to cover 4 topics this morning. I'll start with the rationale for measuring exercise capacity in heart failure and some of the approaches to take. We'll then move on to prognostication in advanced heart failure with reduced ejection fraction, application to other forms of heart failure, and then use of exercise to help with individualizing therapy. So what's the reason to measure exercise capacity in heart failure? Actually, both heart failure reduced and preserved ejection fraction have similarly impaired peak oxygen uptake, on average about 15 milliliters per kilogram per minute. And to put that into context, you can see what the metabolic cost is of these various activities listed here, such that our patients that are living with heart failure are oftentimes living in close proximity to their maximum aerobic capacity, such that they are oftentimes limited in terms of doing things related to functional independence and more vigorous physical activity. And so their exercise intolerance does impact how they feel, it impacts how they function, is highly prevalent. And importantly, I think as a heart failure community, we do a better and better job now of decongesting patients. So even in states of optovolemia, exercise intolerance persists and is often severe. And we also know that you can see that 15 mLs per kilogram per minute average, and that serves as somewhat of an inflection point here in that the patients who have lower exercise capacity have worse outcomes. This is heart failure hospitalization. The same can be said for mortality. So there's a strong relationship between the level of exercise intolerance and the prognosis in patients with heart failure. So there's several different ways to go about measuring exercise capacity. I don't know if it's possible for me to move the top part here. If I hit OK, that way maybe I'll just move this so that we can see the titles. That'll be out of the way down there. Okay, so if we think about comparisons, we do this all day when we see patients in clinic, right? We oftentimes will document their New York Heart Association class. More so in clinical studies, we'll do KCCQ or Minnesota Living with Heart Failure questionnaires and 6-minute walk tests. We are using actigraphy more and more, and I'm going to focus some of my comments on the use of cardiopulmonary exercise testing this morning. All of these have strengths and limitations in terms of their utilization for patients with heart failure. So if we think about New York Heart Association class, it's used in the guidelines, it's used for clinical trial entry, it's used for FDA labeling, and for guidance on treatment decisions, but it doesn't perform very well if you think about it objectively. NYHA class does not predict outcomes in heart failure. There's substantial overlap between the two categories most patients are placed in, which is class 2 or class 3. There's very low reproducibility, and there's really no cardiospecificity. If somebody's a NYHA 2 or NYHA 3, does that really mean that the limitations that are described are governed by a inadequacy of cardiac performance or not? And so I think this has been kind of a historical precedent for NYHA class, but it really, if you line it up compared to other objective indices of exercise capacity, it doesn't perform very well. The understanding patient's perception, of course, is critically important. And among the different tools for patient-reported outcomes in heart failure, the KCCQ has the highest validity and the highest sensitivity to change. But it, like NYHA class, does not provide objective physiologic measurement that has cardio-specificity to why a patient is reporting a given degree of impairment. And then finally, actigraphy is certainly of great interest. I've got my Apple Watch on this morning to track my activity over the course of the day. And it gives this high density data, which is very attractive and complements things like measurement of peak exercise capacity for sure. But there's still need for further validation of the measurements in the heart failure patient population. So some of these limitations are addressed by use of cardiopulmonary exercise tests, which is denoted by the increases plus signs there, which we'll get into in some more detail. So I've put on the y-axis, if you will, some of the heart and pulmonary vascular limitations versus extracardiac limitations to exercise capacity. If we do a 6-minute hall walk, for example, it does give us quantitative information about how well somebody can walk and how far they can walk in 6 minutes. But again, it doesn't give us any information about what is limiting them in terms of their exercise capacity. As we move from left to right, we get more understanding of the cardiospecificity of exercise limitation, but we also get more invasive and more costly and more need for center expertise. So something like an exercise echocardiogram, for example, will tell us information about electrocardiogram and blood pressure and heart rate, estimations of filling pressure, so we can start to really assign the relative degrees of abnormality in different organ systems that are governing exercise capacity. And I put the non-invasive cardiopulmonary exercise test in a similar category as an exercise echo in terms of giving us gas exchange information that complements blood pressure, heart rate, and ECG findings. And then we'll spend some more time today talking about the invasive cardiopulmonary exercise test, which to me, permits us to have the most information that can essentially track oxygen from its uptake through alveolar ventilation, lung diffusion, transport via the cardiovascular system, and then utilization in skeletal muscle such that we can map the O2 pathway in a way that permits us to assign organ specificity to exercise intolerance, which becomes quite relevant in heart failure because it's not always just about the heart in terms of the functional limitation in these patients. And so I'll spend the next few minutes talking about heart failure with reduced ejection fraction. And I will say in the patient that has an established low ejection fraction, I know you have a very active transplant and BAD program here. I find the non-invasive form of exercise testing to be quite adequate for the sake of prognostication. And then when we start to get more into heart failure, preserved ejection fraction overlaps with peripheral muscle conditions and pulmonary vascular conditions and so forth, then the more detailed invasive testing becomes of higher clinical utility. So cardiopulmonary exercise testing, we know that it's evolved quite a bit. I think it at one point there was use of mass spec and Douglas bags to perform this testing, long time to calibrate the metabolic cart, manual data processing. All of that has changed. The modern metabolic carts have really come a long way. You can calibrate them in an automated fashion. You can integrate the cardiopulmonary exercise testing with other measures in terms of thinking about imaging of the heart, invasive hemodynamics, arterial blood gas measurements. There was a very nice article by Dr. Hundley from just the last year in Cardio-Oncology, coupling cardiopulmonary exercise testing with cardiac MRI in order to elucidate the relative mechanisms of exercise intolerance in patients from the Cardio-Oncology clinic. And so it's become easier and easier to integrate the gas exchange measurements that you get from a cardiopulmonary exercise test with other physiologic measurements during exercise. Okay, so back to this busy table. The CPET basics are that we get information that we get from a stress test, and we can also gauge maximum volitional effort. You know, what's the respiratory exchange ratio? Does the patient surpass their anaerobic or lactate threshold, as denoted by the respiratory exchange ratio, typically in excess of 1.05? We know we see better outcomes prediction than we do with a 6-minute walk test or an NYHA classification. It's highly reproducible. There's no training effect, and the cost is similar to an echocardiogram. Some will say that a cardiopulmonary exercise test is limited because it measures peak VO2, and most patients don't spend a lot of time at their maximum exercise capacity in any given day. But I want to strongly refute that, and that when you perform one of these tests, you should actually look at the data from the resting metabolic rate through the onset O2 kinetics to the aerobic contribution to exercise throughout exercise, the anaerobic threshold, the peak VO2, and the recovery patterns. So you really do get the full spectrum of metabolic measurements throughout rest and exercise when you perform one of these tests. So in terms of thinking about the established heart failure reduced EF population, let's talk about the kind of a simple approach to performing these tests. So we're measured, the CPET gives us gas exchange measurements for VO2, VCO2, minute ventilation, and there's different ways to display these. This is a real-time display from a patient from the Framingham Heart Study. We recently performed over 3,000 of these tests. And to me, this is a simple way of visualizing data kind of real time as it comes off the metabolic cart. We want to look at the relationship between use of O2 and external work, sometimes termed the aerobic efficiency. We want to look at how efficient your breathing is. How much minute ventilation does it cost in order to eliminate CO2? And then the CPET will break down a heart rate response to exercise, and then the O2 pulse, or the VO2 divided by heart rate. And then finally, in this lower screen here, we can look at the VO2 in red, VCO2 in blue, minute ventilation in green, in order to give us additional information about the exercise test. This is a normal individual who came through the Framingham Heart Study. In contrast, this is a patient with high-risk features of heart failure. This gentleman actually underwent a heart transplant approximately 2 weeks after this test was done. And you can see a very different pattern. The relationship between VO2 and work isn't close to 10 where it should be. It's more like 5. And this is an indicator of how much aerobic exercise can be performed during the onset of an incremental ramp, which is shown here in black. You can see that unlike our subject that I showed previously that had a VE to VCO2 slope in the 20s, this patient has to have over 50 liters of minute ventilation to eliminate 1 liter of CO2. So very inefficient ventilation. An adynamic heart rate, a relatively adynamic O2 pulse, and then this oscillatory ventilation pattern with very low VO2. And so we know aerobic efficiency is related to symptoms during low-level activity. We know that VE-VCO2 slope potently predicts how patients are going to do. You can see these 4 strata will tell you out to 12 months whether somebody is going to be better off with a transplant or a VAD or not with this singular measurement. We can look at relative contributions of heart rate and the product of stroke volume and peripheral oxygen extraction. And then having this measure of oscillatory ventilation is a major determinant of poor outcomes when you see this pattern. We know from landmark work from Donna Mancini back in the early 90s that Donna basically said that, she wanted to know what VO2 cut point was there that would confer increased mortality relative to somebody undergoing a heart transplant. And that's where the cut point of 14 milliliters per kilogram per minute came up based on this relatively small study of 114 patients in 1991. And it's largely stood the test of time. Ejection fraction doesn't help us that much when you get down into this advanced heart failure population. And so we can put these different gas exchange variables together. VE/VCO2 slope complements peak VO2. And also the reason that it's such a potent prognostic indicator is probably because it gives us insight into right ventricular pulmonary vascular function. If we look across at a small study from our institution, the VE/VCO2 slope correlated with right ventricular ejection fraction and with pulmonary vascular resistance during exercise, because it's basically giving us an indicator of VQ matching in the lungs with poor RV function causing underperfusion of the pulmonary circulation. And we know the right hearts are larger and more dysfunctional in those with a steep VE/VCO2 slope with more impaired metabolic function. And so the VE/VCO2 is a nice complement to peak VO2. But there are some limitations in terms of things to keep in mind with regard to interpretation of the VE/VCO2. We know that if you've got a linear response, which is common in heart failure reduced EF that's advanced, you can, of course, interpret this slope during low-level exercise, intermediate, or maximum exercise. But as you move into a more well population and more preserved cardiac function, you oftentimes will see a two-component response to VE/VCO2. The first is a more shallow, and then you see this very steep late response as patients begin to hyperventilate. We need to be careful not to include the late hyperventilatory response to exercise because that tends to be higher in people who have greater functional capacity. And so that's something that we've kind of looked at relative to invasive hemodynamic data and outcomes data. And in patients that have a two-component slope, you're better off looking at the pre-AT component of that slope. Okay, I mentioned oscillatory ventilation earlier. You can see the pattern here. You can see this pattern from across the room in the exercise lab. When it's present, you see these regular cycle lengths. This is also a patient who no longer has the heart that he was born with. You can see this very long cycle length here and large oscillations. And what we've found when we look at these patterns in patients that have invasive hemodynamic monitoring during exercise is that those that have exercise oscillatory ventilation, which is essentially an extension of periodic breathing, an extension of the Cheyne-Stokes respiration that you'll sometimes see in patients that are in the ICU, it correlates very closely with the degree of impairment in your cardiac output. You have this prolonged circulatory time, and we can see that if those intervals tighten up and the amplitude falls, this happens when you augment cardiac output. And so we think this is a quite cardio-specific finding. The cycle length and the amplitude are both proportionate to the degree of impairment in cardiac output during exercise. And these are measurements that are done, of course, non-invasively by simply looking at the minute ventilation pattern during exercise. And these are 5 different studies, different prevalence of exercise oscillatory ventilation in the studies. But you can see whenever it's present, it confers about 3-fold increased risk compared to those in the same population that don't oscillate, with mortality rates at 1 year ranging from 29% to 50% across these 5 studies. So clearly well in excess of the mortality that we'll see if we send a patient to our surgical colleagues for heart replacement or a VAD. There's more measurements in terms of exercise that we can derive. Remember, I mentioned earlier, pay attention to post-exercise. How quickly does the VO2 recover after exercise? What we see in patients that have particularly severely impaired cardiac performance during exercise is that their VO2s fail to rebound quickly after exercise. There's a delay before the VO2 begins to fall. And if that delay is in excess of 25 seconds, whether you're looking at severe heart failure preserved or reduced ejection fraction, it's associated with poor cardiac output, worse survival, and importantly, it does not correlate with CaVO2. And so again, getting to some of this cardiospecificity in patients with advanced heart failure. What about the role of obesity? I think all of us see patients in clinic, and we wonder how much of their exercise intolerance is related to the fact that they are obese and how much of it is related to the fact that they have underlying cardiovascular disease, whether it be heart failure or otherwise. And so we've been focused on the first 3-minute period of exercise. We do 3 minutes of unloaded exercise, and then we do an incremental ramp. In the heart failure population, typically a 10-watt per minute ramp. And you can take advantage of this initial part of exercise to quantify what is the metabolic cost of moving your limbs, either during cycle ergometry or on a treadmill. And you can see this is an obese patient relative to a lean patient, where the lean patient will typically have about a 2-fold VO2 during unloaded exercise for 3 minutes. And in patients that are obese, you'll oftentimes see that they'll have more than 1 liter of VO2 expended just during the unloaded, no workload stage of exercise. So we can begin to use this information to dissect out, and the correlates of this are overwhelmingly with body mass index and with size. And so it can help us with regard to thinking about assignment. We can even assign a kind of internal work, if you will, in this case, 75 watts versus 30 watts based on the aerobic efficiency pattern. And then when we look across patients, those that have these high internal works, are going to benefit most in terms of their exercise capacity by aggressive weight loss interventions. So in terms of our heart failure reduced CF patient population, this was published a number of years ago. We want to see a maximum effort study. If the respiratory exchange ratio is greater than 1.0 or 1.05, then we can look at peak VO2. Typically, we're looking for values less than 12 mLs per kilo per minute. But importantly, the other patterns, I didn't speak much about heart rate recovery and blood pressure, but a failure to augment systolic blood pressure, slow heart rate and VO2 recovery are poor prognostic indicators. And then when we combine this hemodynamic response with ventilatory efficiency and stability, inefficient ventilation with VEV-CO2 slope, and then unstable or oscillatory ventilation, any combination of these patterns will confer a more than 20% 1-year mortality. And this is where we will move patients into the pipeline for consideration of advanced therapies if they're otherwise appropriate. Conversely, if you can achieve a peak VO2 in excess of 20 mLs per kilo per minute, and you don't have these ventilatory patterns, then your risk is extremely low in terms of your 1-year outcomes. Some patients will not achieve a sufficient respiratory exchange ratio, in which case we tend to focus on the anaerobic threshold and the oxygen uptake efficiency slope. I know this is a very experienced transplant and bad center, so these things are really reviewed for you, but these are some of the things that we want to see in terms of ruling in bad or transplant. Remember that the contributions of anemia and iron deficiency or pulmonary mechanics or abnormal or inadequate pacing can all contribute to exercise intolerance in terms of potentially reversible things to address before moving on to advanced therapies. So all of what I just mentioned is ascertainable with a very simple, non-invasive cardiopulmonary exercise test. It takes about 15 minutes. And now I'm going to pivot some to thinking about other forms of heart failure and what we can learn from perhaps more advanced forms of cardiopulmonary exercise testing. I find heart failure preserved ejection fraction to be a significant challenge. One of the reasons for the challenge is that if you look across the table here, these are societal definitions of heart failure preserved EF, clinical trial definitions. No two are the same. They include different parameters by echo, different biomarker cut points, different alternative measurements, different criteria by which you rule out other conditions. So if we think about, I consider myself a simple-minded cardiologist, I can look at an EKG and say, this is an ST segment elevation MI, right? Or this is ventricular tachycardia. We can't do that for heart failure preserved EF, right? We have to figure out how can we combine these things and the different, components of ruling in or ruling out the condition. And so it can be helpful to be able to assign, in this concept of a cardiospecific limitation to exercise, and not just assign what the relative contributions are, but also to put them into rank order, can be helpful in my experience with taking care of this patient population. So this is our setup at MGH. We prefer to perform upright exercise, whether it be the non-invasive or invasive forms of exercise. This woman has a radial arterial line here and a PA line in the right IJ. And what this permits us to do is to measure the metabolic rate during exercise. We'd have a first pass radionuclide ventriculography camera here where we can image the left and right heart at rest and during exercise. And then we have continuous hemodynamic monitoring where we can monitor the PA pressure, monitor radiator pressure, monitor arterial pressure here. And then each minute we draw a mixed venous blood gas from the proximal PA and a blood gas from the radial artery. And that will permit us, in conjunction with the metabolic rate, to derive the fit cardiac output. So we have fit cardiac outputs each minute. We have first pass imaging in some patients, not in others. And we do this during a continuous ramp cycle ergometry exercise. During upright exercise, patients will typically achieve more than a twofold higher exercise capacity than they will achieve if you lie them down on a cath lab table and put their legs up above them and have them try to exercise for invasive hemodynamic exercise testing in the supine position in the cath lab. So we think there are advantages to this. When patients perform invasive upright exercise testing, they get to exactly the same peak VO2 as they do when they perform a non-invasive test. And that's permits us to measure peak VO2 with this form of testing. And as mentioned before, we can kind of map the O2 pathway when we perform these tests. So where this becomes relevant is that oftentimes patients will have normal resting filling pressures. Right nowadays, they're on their SGLT2 inhibitor. You've got them well diuresed. They're being followed carefully in clinic. And they oftentimes have normal resting wedge pressure, as shown by Maggie Redfield and Barry Borlaug a number of years ago. But when you subject them to the stress of exercise, you see this exaggerated increase in filling pressure in contrast to non-cardiac dyspnea here. You can certainly take alternative approaches to the ruling in the diagnosis of heart failure preserved EF. Even with rapid saline loading in the same patients, you can see that exercise results in a more exaggerated differentiation of controls and HFpEF. So I think it's a very physiologically relevant perturbation. And in our group, we've described this pressure flow relationship where we look at how much the wedge pressure increases relative to the cardiac output increase as a kind of integrated barometer of cardiac performance. Those with established heart failure preserved EF have a much greater slope of the wedge pressure relative to cardiac output. And because maximum exercise differs from patient to patient and is intensity dependent, we feel rather than a single cut point, the pressure flow relationship will permit you to essentially normalize to the amount of exercise somebody does. This pressure flow slope in excess of 2 has now been validated across 27 different studies, where you see the dark black lines are those with HFpEF and the gray are those without. So you can see those that have a steeper than 2 millimeters of mercury per liter per minute slope is indicative of a state of heart failure preserved ejection fraction, as opposed to a more normal hemodynamic response to exercise. Importantly, what does this mean? Is this a kind of just a physiologic variant where you measure it one time, and then if a patient came back to the lab 5 years later, they would have the same pattern of response, but it didn't have clinical ramifications? Or does the exercise hemodynamic response actually give us incremental information about what's going to happen to these patients. We now have studies, many just within the last few years, in over 2,500 patients, looking at wedge pressure responses to exercise, predominantly indexed wedge pressures, indexed to workload or indexed to cardiac output. And you can see that the hazard ratios are well in excess of what you learn from a resting hemodynamic assessment alone. These exercise hemodynamics perform much better in terms of predicting outcomes, cardiovascular event-free survival. And so I think we can, start to move from this concept of a, exercise intolerant patient. What does it mean if they have high filling pressures? To this concept of this being an early indicator of clinically relevant and significant heart failure preserved EF, and potentially a more treatable stage of heart failure with preserved EF. So I think that this is prognostically relevant. It is exercise hemodynamics are making it into the HFA-PEF algorithm for the diagnosis of heart failure preserved EF. The universal definition of heart failure now includes objective evidence of cardiogenic pulmonary or systemic congestion, either at rest or with exercise perturbation. So I think these exercise hemodynamic patterns are becoming more and more clinically relevant. Ideally, we can ascertain them without putting catheters in all of our patients. But what about the concept of kind of individualizing care on the basis of these physiologic responses to exercise? I'm going to talk about some of these this afternoon as well at the medicine grand rounds, but we'll delve into some of the kind of the predominant profiles that we can ascertain with exercise testing. So I oftentimes think of these patients as having multiple deficits, and the question is, what are the relative deficits for a given patient in terms of thinking about what's basically normal, which is filled in, and what's deficient, if you will, in a given patient. And so if we think about LV dysfunction, we just showed some of the data in terms of hemodynamic profiles. If we perform one of these tests and we find that the wedge pressure to cardiac output slope is steep, or the wedge pressure goes up in excess of 25 millimeters of mercury or 20 millimeters of mercury in the upright position, it's helpful in terms of ruling in an impairment in left heart performance. We can also use this testing to assess the pulmonary circulation. And for the pulmonary circulation, we look at the pulmonary vascular resistance during exercise and the transpulmonary gradient relative to cardiac output, which should fall less than 1. But we can also understand other conditions. Does the patient have a completely flat hemodynamic response in terms of the right atrial pressure and the wedge pressure due to inadequacy of venous return during exercise, and as a result, they're impaired with their stroke volume response to exercise? Do they have impairment in the ability to utilize oxygen in the periphery, or do they have abnormalities in their pulmonary mechanics? And so we can also kind of begin to get at alternative diagnoses. And then, there are now these very specific interventions, which are very much a work in progress in terms of these types of responses, specifically responses to exercise. So, for the many intra-atrial shunt studies that are ongoing, you specifically want to see a steep wedge pressure response to exercise, and not only a steep wedge pressure response, but also a modest right atrial pressure response, right? In order to see that gradient be there to create a scenario in which patients undergoing offloading of the left ventricle and left atrium will stand to potentially benefit. This is early work by Feldman with reduced LEP1, where you can see in red is pre-shunt, in blue is post-shunt in terms of a reduction in resting and exercise pulmonary capillary wedge pressure. The reduced LEP2 study, sorry, this is a busy slide, was a completely neutral study. Win ratio is 1.0. Further assessment of this data suggested that those that had higher pulmonary vascular resistance, not at rest, but during exercise, did worse with the shunting which makes sense in terms of thinking about where the limitation is and the implications of moving more blood to the right heart. And those without exercise PVR elevation seem to improve. This will be tested further in the responder trial. Certainly not ready for prime time. But an example that I wanted to show for the sake of this concept of kind of individualized treatments on the basis of hemodynamic response patterns that are not going to be manifest if we confine our assessments to rest alone. What about pulmonary vascular resistance? We know this confers worse outcomes in our patients. Similarly to the wedge flow slope, we know the PA pressure cardiac output slope in excess of 3 confers worse outcomes, including those that have normal resting hemodynamics. And there's a number of studies ongoing. We recently completed a pulmonary denervation study with invasive hemodynamics at rest and exercise, and have another one that's about to start. Levis amended is under investigation for this combined pre and post capillary pH population. Again, with both rest and exercise hemodynamic profiling. Importantly, we need to do a better job of coming up with non-invasive strategies to assess these patients. I certainly don't want to leave you with the message that every single patient that comes through the door with suspected HFpEF needs to have an invasive cardiopulmonary exercise test. So we do look for patterns. One of those patterns is simply looking at the O2 sat response to exercise and then comparing that to patients that have a transpulmonary gradient or a wedge pressure predominance during exercise. Up here in blue are those that have high transpulmonary gradient in excess of wedge pressure during exercise. And you can see these patients that have lower PaO2s with their arterial blood gases and lower systemic oxygen saturation. So whether we look at PaO2 or simply the SAT probe, those that have a predominance of precapillary pulmonary hypertension tend to be the ones that desaturate during exercise, and patients that have isolated left heart dysfunction, even if the wedge pressure goes up to 40 during exercise, we do not see their O2 saturations fall. So this is an ongoing effort to come up with non-invasive correlates of some of these invasive patterns. Chronotropic incompetence, this is something that we can easily assess during non-invasive exercise testing, and I will try to convince you that when we just look at resting heart rate alone, we don't know what the contribution of heart rate inadequacy is going to be to somebody's exercise intolerance. These are two patients, identical peak VO2. The patient shown here has a totally normal heart rate response to exercise, and all of their impairment is in the O2 pulse or the stroke volume extraction product. This patient, same peak VO2, but has a heart rate of 60% of predicted and completely preserved O2 pulse. Again, we only can understand this if we measure the heart rate response to exercise. And I would argue that these two patients should not be treated in the same way in order to improve their exercise capacity. I know there's been work done with physiologic responses to ivabradine here at VCU. These studies I found to be quite interesting. We really want to have an interventional study to understand the role of heart rate response in HFpEF. If you give patients ivabradine, their peak VO2 goes down. If you withdraw their beta blockers, their peak VO2 goes up. There's an ongoing study at UPenn called Block HFpEF, looking at a randomization to beta blockade or amlodipine to see what happens to exercise capacity. But this is starting to become convincing evidence that the slow heart rate response to exercise plays a role, at least in some of these patients with heart failure preserved EF. In terms of the periphery, I'm just looking at my watch. I want to make sure to leave plenty of time for questions. This has been an area of significant interest. I think these same patients that have this systemic disorder of heart failure preserved ejection fraction do not have abnormalities that are confined to the heart. They oftentimes have very abnormal periphery. And if we actually look at VO2 relative to extraction of oxygen in the periphery, and we compare HFrEF, which not surprisingly, if you look at the bottom blue line, the ability to deliver oxygen, the convective O2 supply which is governed by cardiac output during exercise, is very low. If we look at a normal individual, obviously much better convective O2 delivery, and then the HFpEF is intermediate. However, if we look at these dashed lines, this tells us how much diffusive O2 conductance there is in the periphery. How well do your peripheral muscles utilize that oxygen that you're delivering? And in this case, it's a different story. The HFpEF folks here in red are the worst off, as shown by this bottom line here, such that if you take an average HFpEF patient, and these are all measured ABGs and BBGs, you can see that if you corrected their peripheral oxygen utilization, you would achieve this degree of increase in VO2. If you correct their convective delivery or their central abnormalities, you would achieve a more modest increase in VO2. And this is what motivated our interest at MGH in iron therapy for heart failure, because we know if we give patients iron, that we can increase O2 delivery with increasing in hemoglobin, and we can also potentially improve oxygen utilization through effects of iron on the ability to use oxygen in the periphery. And so that's what motivated us to perform this iron MET trial, which is currently enrolling. It's an NIH-sponsored study, single dose, high dose iron versus placebo. And it's a 2-to-1 randomization. We give ferric hydroxymaltose, which you can give up to 2 grams at a time. And we bring them back 12 weeks later and have them perform another cardiopulmonary exercise test. So a very kind of simple design. We're also interested in intervening in the periphery. You know, there's going to be all of these weight loss medications that are going to be used more and more in this population, but these patients lose not just fat mass, but lean muscle mass as well. And so we're quite interested in activin ligand traps in order to try to preserve skeletal muscle mass, while also potentially having beneficial effects on low hemoglobin levels, diastolic function, and pulmonary vascular function. And so this is part of a AHA strategic network that was just funded last week to look at activin ligand trap interventions in HFpEF and their relative response in conjunction with exercise training. So there is a great deal of work ongoing in HFpEF. This is a slide that was courtesy of Sanjeev Shah. All of the studies I show here, some of which I didn't have a chance to get to, are relying on exercise-based phenotyping to select patients for heart failure preserved EF trials, and also oftentimes used as a primary endpoint of these studies as well. Where do we go from here? You know, we need to do more non-invasively with this patient population in terms of not subjecting them to invasive hemodynamics. We're very eager to substitute echo for these patients, but it's easier said than done. And we're also very keen on identifying biomarker signatures that can potentially supplement or take the place of the invasive hemodynamics. And so all of these patients undergo blood sampling that have this type of testing, PA blood sampling, radial arterial blood sampling, as well as a SVC sample. So we can look at multi-site, multi-time point samples for these patients. And we're in the process of measuring their metabolite responses relative to the hemodynamic patterns, eicosanoid responses. I know there's been a great deal of work in inflammation and heart failure here at VCU, protein responses to exercise and how they track with things like peak VO2 and peripheral oxygen extraction and wedge flow slopes. And then the HeartShare program, which is actively recruiting to do this kind of deep phenotyping of patients with HFpEF. So I'll stop there. In conclusion, quantification of exercise response patterns in heart failure provides prognostic information in HFrEF and helps us with diagnostic precision in HFpEF. And this subphenotyping that I just briefly described on the basis of specific deficits may help us with characterization and treatment of HFpEF. And there's certainly a lot of opportunity for collaboration in this space. So thank you very much. I'd be happy to take any questions. I know that there's also people online. I hope you're able to hear me okay. So if there's questions online, I'd be happy to field those as well.
I have a question. Thank you for this wonderful talk. All of those parameters that are based on normal physiology of the person, but most of the patients with heart failure are based on this dual electric therapies, and many of them can compound. Just starting with your heart rate, your overall voice patients, when you test them, depending upon how much they responded to the diuretics. How do you take those things into consideration when you treat one patient?
Yeah, it's a great question. I think that, and we have to be humbled by the fact that the physiologic state can change over time, and so we aren't necessarily measuring what's representative of what's happening a month before or a month after somebody comes in. But I will counter that somewhat by saying, what have we done historically as the cardiovascular community? We send somebody to the cath lab, for example. We say, we're going to do a right heart cath, gold standard assessment of the wedge pressure, the cardiac output, and exactly to the point that you just made. Well, when was their last diuretic dose? Did their cath happen at 3 o'clock in the afternoon and they've been in NPO since 8 p.m. the night before? Did they hold their beta blocker or not? And importantly, when we make those gold standard measurements, we're making one measurement under one physiologic state, right? And I would counter that when we exercise patients, on average, we get about 11 matched measurements of cardiac output, wedge pressure, PA pressure, pulmonary vascular resistance derivation. And so we can create this pattern of what happens when you change venous return to the heart, when you basically load the heart, and then we can make these repeated measurements. And I think what we're doing with exercising patients is we're oftentimes just getting more precision on our phenotype because we're able to look across more of a physiologic spectrum to the exact point that you made, which is, we don't capture the whole physiologic state. I think we really don't capture it when we focus on a singular measurement. And that's been borne out. It's not just exercise, right? If we look at patients that have the CardioMEMS devices in, right? Patients that have serial measurements over time gives us additional information to just that like singular measurement. Yeah.
Thank you for the wonderful discussion. I have 2 questions, but I'll start with the first one. In patients with the obesity-related phenotype of HFpEF, now there is a lot of interest in weight loss and with caloric restriction, GLP-1 receptors, and others. And the measurement often the outcome is improvement in VO2 peak adjusted by body weight.
Yes.
And you say these patients lose weight and their VO2 peak is increasing, but then their absolute VO2 is not increasing, even going down in some cases. And so should we consider that an improvement really of fitness level in those patients, or should we start using a metabolic cost in this population?
Can you repeat that for the
Yes,
online audience?
I will. It's a terrific question. It's a question about, what happens with obesity and when you treat obesity. We've got the recent data from the STEP HFpEF study, and I'm sure that you would see the same thing if you did the study in HFrEF, where reduction in body weight confers improvement in that particular study in 6-minute walk distance. Yes, you see improvement in peak VO2 index to body weight because the body weight goes way down. However, a lot of weight loss strategies cause proportionate reduction in fat mass and in lean muscle mass. And they already have this whole kind of sarcopenic obesity problem. I plan to talk about obesity this afternoon in the medical grand rounds because I thought it would be relevant to the whole, internal medicine community and the implications of some of the trials that are being done. So to answer your question, it's not appropriate, I think, to just simply look at VO2 indexed to body weight. It'll help you get your, significant p-value, I'm sure, at the end of a trial. But I think what we really want to do is to figure out, is there ways to potentially preserve lean muscle mass while reduction in fat mass take place, such that we can then look at how much does that internal work cost go down? How much does your absolute VO2 go up? And that's where I think we have an ongoing study being done with a metabolic accelerator, which appears to have some predominance of fat loss relative to lean muscle mass loss. We're very keen on coupling potentially some of the weight loss medications with the activin ligand traps in order to try to preserve skeletal muscle mass. That's going to be the project through the AHA network. And so I think your question's a great one. And then, by the way, if patients stop their obesity drugs, not only do they gain weight back, but it turns out the weight that they gain back tends to actually have a greater fat predominance than the weight that they lost. So it is a real issue. Terrific to see patients losing weight, but I don't think that we're done yet there. So to answer your question, yeah, I think it's important to look at totality of VO2, workload that somebody can achieve. We're doing a weight loss study, and I can tell you that the VO2 does not go up proportionate to the amount of weight loss. Greg?
Yeah, Greg, could you comment on the role of exercise in the patients where you were showing with exercise, there's an abrupt increase in pulmonary capillary wedge pressure?
Mm-hmm.
And maybe also just comment on the role when you see that in patients with obesity. How do we avoid, some pragmatic strategies, whether it's strength training or resistance training or aerobic training to preserve some of that skeletal mass?
Yeah.
Complex question.
No, thanks for the question. I know this is an area of, of expertise of yours in terms of the cardio-onc patients, and these patients are clearly limited. I'm going to talk about this also at noon in terms of this whole concept of like some of heart failure preserved is it's an exercise deficiency syndrome, right? These patients, they don't exercise over a course of a lifetime, and as a result, they have smaller hearts. They can't mount as much stroke volume, and what they really need is you need to replete their exercise deficiency. But doing so can be challenging, particularly for the patient who is morbidly obese, such that when they start to exercise, what you see is that they have a dramatic increase in the VO2. And, with that increase in VO2, this also incurs a similar increase in wedge pressure. So these patients have the steepest increase in wedge pressure. So one of the things is to limit the exercise that they're doing that involves supporting the totality of their body weight. So patients like this are going to have an awfully hard time walking up a flight of stairs or going up an incline. But if you start them off with exercise programs that involve supporting their weight, oftentimes a cycloergometry exercise, swimming exercise, pool-based aerobics, things like that can be really helpful in terms of partially supporting body mass as they're ramping up the exercise. These patients are increasingly being put on weight loss medicines, which I think, handled the right way, can be super effective. But the message definitely is not, oh, the wedge pressure is going to go up, when you start to exercise, so let's steer clear of exercise, because that's really what they're deficient in. But your point is certainly well taken in terms of the way these patients exercise has to be different than just telling them to go to the gym and run on the treadmill. Yeah.
So we're all used to using cardiopulmonary exercise testing for identifying the high-risk patient. But you highlighted that some of the parameters are become very abnormal with rising pulmonary vascular resistance or progressive sarcopenia. Is there a point where they're too sick and the CPAP can be a flag for, well, this is, the horse is out of the barn. Don't consider transplantation. Is there any data on the too sick patient?
Yeah.
Repeat that. Sorry, they can't hear them.
Oh, sure. Yeah. And I don't know if there's been anything come in through the chat. There's been some great questions from the live audience here, but I'm happy to try to get to those. So to your point, I didn't get to this, but one thing that can be very helpful with regard to this too sick and there's been some really nice work done by Larry Allen and others, and I'm sure you're familiar with in terms of the VAD population, where you want to try to tease out what's the reversible frailty and what's the non-reversible frailty, right? And so to me, looking at, if you do an invasive cardiopulmonary exercise test, even in the HFrEF population, if you look at the slope of the cardiac output relative to VO2, that can be quite helpful in terms of this concept of how much of the limitation is driven by the heart, right? And so if you've got a very shallow slope, less than 5, then that means, that you really can attribute that abnormal VO2 to poor cardiac performance. And obviously then you're going to try to replace the heart accordingly. In a subgroup of patients with heart failure, they will have very abnormal peripheries. They'll be highly deconditioned. They'll have very poor skeletal muscle function. Sometimes they'll have a skeletal muscle myopathy, or they'll have severe pulmonary dysfunction with pulmonary mechanical limitation. So yeah, I find CPET to be helpful in also kind of understanding the patient who has this kind of extra cardiac frailty as well that may not reverse with transplant, particularly as we start to get into some of the pushing the envelope on the age of the patients that we transplant and things.
Yeah, I got one question. As somebody who is just beginning training, sometimes the data here can be very intimidating. Like, so other than a peak VO2 of less than 14, which other variables would you say, like somebody who is a beginner needs to be aware of in terms of taking care of these patients?
When our trainees come through the lab and this cardiopulmonary exercise resides in kind of an unusual space, right? Because as you're doing your cardiology training, right, I'm sure you're spending time in the cath lab and spending time doing echocardiograms and things like that. And cardiopulmonary exercise is not historically incorporated within the curriculum of cardiovascular fellowship. And so it's not surprising that it becomes somewhat of kind of a black box. I tend to refer our fellows to this relatively simple diagram where we are trying to look at variables that are associated with increased risk. And so you can just compartmentalize it into oxygen uptake patterns, non-invasively derived hemodynamic response patterns, and then the efficiency and stability of ventilation. If you look across those 3 domains, you get a reasonable insight into the limitations of the patients. All right. You're welcome. Sorry to go over here. Thank you for the lecture.
You can always.
Oh, they heard? Okay. Yeah, sure. If there's questions, I think if I didn't, I'm happy to give it. My email has become simplified now that we're MGB. So it's just glewis@mgb.org. If there's any questions from those that are on Zoom or in the audience.